Thank you very much, Annette. I'm very impressed that after 6 months or so, we can started this kind of same-day ART at the Anonymous Clinic, as you heard. I'm too old. Too old means very easy to be seduced by certain ideas. If you remember that at the opening ceremony, I said that this meeting here is always, besides information, education, we always put in certain advocacy aspects, starting from test and treat, PrEP, and now it's same-day ART. I told my colleagues here that, because I heard that Diane Heffler, I think 2 years ago, so when I came back from that meeting, I said, we should do this at our Anonymous Clinic. And then after a year or so, when last year I asked Diane to come to give a lecture, and then after that, 6 months after that, we then started the same-day ART at the Red Cross, using Red Cross own money for several things, for drugs and many other things. And fortunately, we also have USAID to support certain infrastructures in doing this one. So otherwise, this cannot happen. Also, this cannot happen if we don't have Dr. Nittaya, we don't have Pit, for example, to help doing this thing here. So you know what I mean by next year, we again, repeating advocacy on the same-day ART. So I think everyone here more or less agrees that the benefit of same-day ART versus conventional ART initiation benefit much over harm. Okay. However, we do have certain reservations, certain challenges, certain considerations or concerns among practicing doctors. So that's why I asked 3 ID doctors to come up here. This is not a debate, not a debate. Debate maybe next year, but kind of to hear from them in terms of after hearing what Linda-Gail, Nittaya, and Pit presented to you already. What are the still concerns, or what are the suggestions, or what are the reservations that we must have this before we can start that? Okay. So these 3 ID doctors here, they are almost on the same age as Dr. Nittaya. Starting from Dr. Sasisopin, Professor Sasisopin is professor from Ramathibodi Hospital. The first one. The next one is Dr. Supani from Tak Sin Hospital in Bangkok. Okay. And the last one there is Associate Professor Iskandar Aswar from University of Malaya in Malaysia. I told Iskandar is going to be the rising star in our Asia Pacific region. Believe me, okay, we can see. So I will ask each of them, without any slide, to tell us about what they thought after listening to all of this, and then if they have any concerns or questions, both Nittaya and Linda-Gail can explain or try to comfort them. This is the answers and so on and so forth. Okay, starting with Sasisopin first.
Thank you, Professor Praphan. I think the same-day ART is a very great strategy that we can reach our target 90, especially the second 90s. So because you know that, as Dr. Nittaya said, that some of the patients lost to follow-up from testing to ART initiations, that that if they lost to the care, so they can transmit HIV virus to other people and can cause the morbidity and mortality because of delayed ART initiations. So I think the same day ART is a very great strategy, but in practice, so what is my concern? My hospital setting is a university hospital setting. We have like more than 1,000 beds in the hospital and more than 4,000 outpatient clinics a day. So the first thing of my concern is waiting time in clinic. So the first one, if you wait for the first HIV testing, it's maybe like 2 or 3 hours. And then if you need another testing to confirm HIV testing, you need another 2 or 3 hours. And about other labs, right now we have like older age, you're concerned about creatinine level. We have like some of the patients have hepatitis co-infection that may have abnormal liver function test. Actually, in Thailand, NNRTI is a first-line ART regimen. Do you concerns about using efavirenz in the patient who have abnormal liver function test? And actually, the CD4 cell count in my hospital, we have to wait like 1 day, like another day for the results of CD4. You may know that in Asia Pacific, more than half of the HIV patients entry to care with a very low CD4 cell count, like less than 200 or maybe about 100 or something like that. So we concerned about the opportunistic infections, as Dr. Nittaya says. I'm really concerned about iris. We don't afraid about if the patient come with the full-blown symptom of TB or cryptococcal meningitis, but we have some patients that have asymptomatic tuberculosis as well as a cryptococcal antigenemia, which means that you have a cryptococcus in blood, but don't still have cryptococcal meningitis. Yes. So you want to wait the CD4 cell count like another day. All lab tests in my hospital we can do for 1 day. We except CD4 cell count, we need to wait for 3 days, and cryptococcus antigen for 1 day. But we can do all lab tests on the same day. So this is a concern for how many hours that you have to wait. So if the patient come to clinic, to the hospital at 9 o'clock, so we can do all lab result, and the result maybe come back at maybe 4 o'clock. So you can still wait. The healthcare worker can still wait until 4 o'clock or 5 o'clock. The patient can wait for the same day if they need. So the second concern is the healthcare provider team and also the counseling team. In my hospital, we have the log system that the healthcare provider who can order or who can prescribe ART. So we lock the computer system just only for the infectious disease staff and infectious disease fellow in both adult and pediatrics. Not all doctor can prescribe ART. But anyway, we have a consult system that you can consult the ID physician every day, including weekend. So I think that one is not a problem in my hospital. You can call if you want to start ART. You can call the ID physician. But another problem is the healthcare insurance scheme, as Dr. Nittaya said. For the patient who want to use the National AIDS program, we have to entry the data in the computer first, and then we can use that drugs. So how come if the patient come on weekend, and who will enter the data to the computers? So that's why the patient can pay out of pocket just for 1 week, and then they can back if we do the data entry on the computer. And I think that's my concern in the practice in our hospitals.
Okay, thank you, Dr. Sasisopin. Let's hear from all, and then you have some response and also some questions from the floor. Dr. Supani.
In my hospital, it's a general hospital, about 470 beds, and situation is the same like the Dr. Sasisopin about the service, because the laboratory guarantee for the C4 about 3 days. So now in the general case that no active OI, the duration of prescribed will be about 1 to 2 weeks. But our concern is about the case that has a borderline CD4 that may have an occult of the infections that it hard for us to find out. And the second is that in case that our team concerned about the readiness of the patients for find out the proper time for take the medicines is our concern. But later is about the retention to care, because I think it's need for the ones or the navigator to follow up the case for retentions. But I think it's the challenge for us to moving for the early ARV, maybe 1 week is maybe in the future, because I think it depends on the service, because we have the connection between the VCT and the ARV clinic in Taksin Hospital, so it's easy for transfer case. But the limitation is about the lab that I think if we initiate, so we can moving in the stable case, but just wanting about the case that borderline CD4. Yeah.
Okay, thank you. Let's hear from Iskandar, Malaysia.
So thank you very much and good afternoon. I have, I'm neither in the pro and con side. I believe this is a timely timely initiative. I think the fact that WHO have made recommendations around rapid initiation of heart, and in particular same-day heart, really should give us the impetus to then think about it at least and move forward. Now, in Malaysia, the settings are quite different from different centers. In our setting, which is University Malaya, we have the ability to scale up services based on the latest medicine, latest evidence. That may not necessarily be the case elsewhere in Malaysia. And I think a lot of other parts of the country are still struggling with sort of with universal treatment. So I think this concept of rapid initiation of antiretroviral therapy is really needs to be placed in the bigger picture of where your resources are and what other people in different parts of the country are also doing. But where you can think about rapid initiation of antiretroviral therapy and where priorities certainly lie would be in those with advanced disease, as mentioned, certainly pregnant women, and those with acute HIV infection. I think those are the areas where we would be most concerned about. Now, just if I could just reiterate the benefits and the harms of same-day antiretroviral heart initiation and complementing maybe Nittaya's earlier slides. I think the fact that patients want to start early, I think that's quite clear given the choice. They feel that trust with the service, they feel more connected to the service, and they're less anxious as a result. So I think that's quite clear when you speak to patients about what they want. I think the short-term clinical outcomes, as presented by Dr. Nittaya and Dr. Linda-Gail, are very good in terms of viral suppression rates, retention rates, and linkage to care. And that's what we'd like to see in terms of improving the HIV cascade. But we don't have any long-term data. It's all short-term outcomes, and it's around 6 months, 12 months, and maybe we. I don't know whether we're going to get any of it, but it would be useful to look at that, especially certainly the data that you're looking when you're transitioning patients to the hospital setting. So I think that's very important. In acute infection, I think rapid heart is, the evidence is there in terms of limiting the viral reservoir. So certainly there's the evidence base for that is huge. But I think infectious disease physicians feel very overall obsessed about ruling out opportunistic infections. We're very, very concerned about that. And especially in centers where median CD4 count at presentations may be less than 200. We're taught right from the beginning about you need to rule out TB, you need to rule out TB meningitis, you need to rule out cryptococcal meningitis. And I think we would find it very hard to let that go when you're thinking about the barriers to rapid initiation of antiretroviral therapy. So a symptom screen is definitely warranted. A clinical examination is definitely warranted. And then this role of cryptococcal antigen. I mean, we do cryptococcal antigen testing at baseline for most patients. It's not the best place to place your resources, but it allows you then to deal with what you then have to do with a positive cryptococcal antigen. And in circumstances like that, you're advised to do a lumbar puncture. And how does that fit in with rapid initiation of antiretroviral therapy? Because in those circumstances, you would want to defer initiation of antiretroviral therapy. Now, some just personal thoughts from my side. We're a university hospital setting. We have a cohort of about 1,500 patients. We see patients in 3 different clinics. We're largely inflexible when it comes to weekend out of hours, work hours. So it would be difficult to sort of arrange that to fit in because there needs to be some flexibility, as clearly pointed out by the presenters. And you need the buy-in of all the ID physicians. I may think it's a good idea, and I think it is a good idea, but everybody needs to be on board with this. And that can sometimes, people have differing opinions about what is worth prioritizing. I think the counseling, on the other hand, can happen concurrently. I think as long as a patient is ready to start antiretroviral therapy, you don't really need all those counseling sessions immediately pre-ART initiation. That can occur concurrently. And I think the mindset needs to change with the HIV counselors and with a lot of ID physicians, because overall prognosis is very good nowadays. I think that's some of the points I probably just want to raise.
Thank you very much, Dr. Iskandar. Now, we heard about these limitations or concerns and so on and so forth. We'd like to hear from the floor here in terms of what are you doing or what's your thought in the Netherlands, in Australia, for example. Either your experience along the, on same-day ART in those countries, or how you can help to relieve those concerns that we heard from the staff. Peter Rice, for example.
I think it's an evolving field. If I look at the Netherlands, and I echo the last speaker's words, it's people's opinions are evolving. So generally speaking, in the Netherlands, you see that physicians are more inclined to start immediately and early. But it's also dependent on the setting. So I was listening to the talks and thinking of our own settings and how do we organize it where about 30% of new HIV diagnoses are made by general practitioners. And I think there would be a reluctance for them to start the ART. So we need to solve the issue of getting people newly diagnosed immediately linked to care. So I think many of the issues are logistics. And the other point to make is the people with acute HIV infection. I agree there. So that's where, at least in Amsterdam, we're doing a program where we're trying to successfully do same-day ART initiation for those newly diagnosed at the Municipal Health Service. And that so far the results actually show the same picture as was shown for Bangkok and San Francisco. And I think the thing that comes through all the time is that the clients themselves indeed are very, very happy about that possibility of not just getting the diagnosis, but something being done about it immediately. So that so far is our experience, and it's evolving. And this was very stimulating, and at least gave me some thoughts going back of how we should maybe improve this.
So are you doing that in Amsterdam?
Excuse me?
Are you doing the same day ART in Amsterdam?
Well, we're doing, as I said, we're trying to do it with the Municipal Health Service. So the Public Health Service, the sexual health clinic, in case people are being diagnosed. But that's Amsterdam. So that doesn't mean that this also happens in Rotterdam and The Hague and other places. So it's not immediately adopted. It's a gradual process.
Okay, how about other countries? Please feel free to share your experience there. Tony Kelleher is looking at me. Do you want to say something?
I would like to echo a lot of the things that Peter has just said. I mean, I think in our province, in our state, in New South Wales, there is a push for this. There is no formal, so there is an encouragement to start as early as possible, and we're being reasonably successful as that at a population basis, and our cascade is looking good. We have, I think it's now 85% of people on therapy by 30 days of diagnosis. So there is certainly a will to do this. I think where it becomes more difficult is where the patients are much more complex, where they come from, they have multiple intercurrent problems, or if they have psychiatric illnesses in particular. So I think that's where it becomes more difficult. So I think we've been successful, but there are definite gaps in instituting this, and it comes to, we have a different set of issues. Cryptococcus is not as big a problem in sort of a developed country like Australia. And TB is not a huge problem, but then there are other NCD problems, particularly the psychiatric ones, that impact on the initiation of therapy.
Okay, Tony, would there be anyone else to say something?
Thank you. This is experience from India. So NACO, our National AIDS Control Organization, has buy-in the concept of early initiation of ART, rapid as well as same-day ART. But the thing is, India is a kind of complex country where we have a wide variety of infrastructure and other issues across our own states as well as districts. So NACO is taking a call, very conscious call in taking this. So although we have not given guideline to the people, but wherever the infrastructure and other things are good, like for example, in well-developed medical college settings, we are strongly recommending the doctors to initiate rapid ART, if not same-day ART. And also the other thing is we have also included this one of the monitoring indicators, like how many people have been started within 7 days of initiation, as one of the informal monitoring indicator during program reviews. So that's how we are trying to scale up this goal.
Okay, thank you. The last question, last comment over the back.
Hi, I'm Tananda from CDC Thailand. I just would like to make one comment related to same-day ART. Personally, I think same-day ART or rapid ART will help a lot in terms of preventing loss to follow-up patients. But just want to make one comment on the data that Dr. Nittaya presented in her presentation for the ART, the second 90 in Bangkok. I think we acknowledge that in Thailand we have the programmatic barrier in terms of insurance that we mentioned by a few speakers. So the 50% ART initiation in Bangkok, we are wondering, is that the true non-ART or not? So we work with Bangkok Metropolitan Administration to try to analyze what happened to those non-ART patients, and we found out that 80% of them are under Social Security scheme. So we work with the Social Security scheme to find out what happened to them. And we did some chart review in around 500 cases in 4 big hospitals, and we found out that 95% of them already on ART. So I think my point is that if we want to really understand the second 90, we have to have the same monitoring system or the good linkage between the different insurance schemes. For Thailand, it's the Social Security and the UC scheme. Otherwise, we cannot see the true picture of where we are in terms of the second 90. So that's, thank you.
Okay, thank you. Congratulations for the first 90. I hope that the first 90 and the second 90 will be congratulations for the second 90. But I hope that the second 90 will be started sooner than 3 months average that's happening here in Thailand. Okay, in order to benefit the individuals and the public. So it is very nice. So like to, we have heard all these things here. I would like to have Linda-Gail or Nittaya trying to tell the group that, besides just TB crypto, which we have to exclude either laboratory or clinically, as well as readiness of the patient. What else that you can comfort the audience here? That this problems, we have to solve the problems. Problems are there. We have to solve not just the problems there. We just do nothing. But how would you advise them how to proceed as much as we can?
So thanks, Praphan, and it's been a real pleasure again, and it's been great to hear how the region is doing. I would just make 2 more remarks. I think the first one is that setting does matter a lot. So I probably failed to say that when we did that rapid initiation, same-day initiation in pregnant women, we did it in the back of a truck. So it was a 6-foot by 4-foot truck, and we had a CD4 count machine and our rapids and a gene expert for TB, and we did it literally right there. And 300 women we processed in a few weeks and showed this, that this was feasible. That clearly is very different to a very busy hospital setting where you have large grey machines doing high throughput CD4s and viral loads, etc. So I do think we have to think about this in terms of setting. And then in terms of decentralization, so certainly in South Africa, we have tried to decentralize as much as possible. I think our narrative is about how we take ARVs to our decentralized places where HIV testing is being done at the moment. So for example, the Anonymous Clinic is now really moving forward on this. I think we can do the same thing, that many of the sites where people are in mobiles, in tents, etc., the ARVs need to go there so that we can just dish them out at the same time. There are some pharmacological, pharmacy legal hurdles to get over for us. And I know pharmacies around the world get very anxious when drugs are, being stored anywhere. So one has to think about that. Even the giving 3 months supply was a big hurdle for us to get over in South Africa, and we now have got to that point. So, I think these are the milestones we have to work through to get to where we need to be. But I think the discussion needs to be, what is the role of point of care? And quicker return of our labs and our monitoring. How much monitoring can we do at the bedside? And what does that look like when we have large numbers to process? So, I think we can start to get more nuanced about the discussion. But I'm hoping that today there'll be a real sense of urgency to have those conversations as soon as possible, and that our goal should be to reduce the time as much as possible. I would say in sort of comfort to my colleagues on the side that if your patient is sitting in your hospital bed, the urgency becomes, obviously we want rapid ARVs, but it doesn't necessarily have to be same-day ARVs in that setting, because they're captive. You're not going to lose them. But I will say to you, the reason we moved to same-day ART in these pregnant women is that my Tutu tester was 50 meters away from the ARV clinic, and I had lost to follow-up from women who got tested 50 meters away. They had to walk there. And somehow they still disappeared. I have no words for this. And so, we said, all right, now let's bring the ARVs here so that we give it to them right here. And we could do it. We did it very safely. We have lots of TB, even in pregnant women. We did it very safely. We had no deaths, no iris, no side effects. So it's very feasible to do. And it's definitely something we should aspire to. But I think we should think setting. And think how we apply it within our own environment.
Okay, Dr. Nittaya.
I think it's the same concerns that I raised in the presentation, that it is not easy, and it really needs the leader in each setting to really say to the team that this is something that we are going to. And if there is commitment there, new ideas, new solutions will certainly come. And to think about having point of care testing machine in some large university hospital is something that we may also have to think about as well. We should not think about point of care testing as something in the drop-in center in a satellite public health service delivery units. That's one thing. The other thing is that I have to say that we ask to have the protocol from San Francisco, because I think that it has something, some infrastructure quite similar to a big city like Bangkok. And in this way it means that you probably may have just a few large testing clinics in the city, and then a few large ART facilities in the city. It does not mean that every hospitals, every ART facilities will need to do same-day ART or rapid ART initiation, but it's just that the HIV testing site would need to do so. So that's why we call the Anonymous Clinic as the same-day ART hub. So it's just a hub, and if we can have a few more hubs in the city, that may be adequate already, and that we get the buy-in from the other hospitals throughout Bangkok, that in a way that they agree and they feel comfortable to get the referral from the same-day ART hub to continue the long-term ART. So we may have to, if you ask Ramathibodi Hospital, a very large BC University hospital, to do same-day ART, I think that may be too challenging. But vaccine hospitals, smaller size, probably easy to get the buy-in from the staff rather than to go to the dean and then to many other steps. Probably is a possible same-day ART hubs in the city.
Okay, thank you. I think at least the audience here should get the take-home message that we should start ART in our patients as soon as possible and try to achieve it either the same day or no more than 7 days. Yeah. This is my pledge to all of you here, not 3 months as average 3 months that we're doing here. Okay. Guidelines, the protocols will be developed by Dr. Nittaya's group and will be shared with all of you here, no matter which country you are from. Especially, I'm very glad that the Ubon Ratchathani Regional Hospital and two Chiang Mai hospitals are interested to initiate the same-day ART approach in their own hospitals. So this will build up more experience around the country, not just in Bangkok and in Advanced Clinic, that we can all do this kind of same-day ART. So we hope that when you get back home, you can always request the protocol, and then we are willing to share with you. By saying so, since I am the last moderator in this session, because this will be the last official conference, although after after I finish my talk, I'll go out to get some box lunch and then come back to a luncheon symposium hosted by Abbott with a very interesting topics in terms of how can we do rapid, not HIV diagnosis, many other rapid diagnosis in our resource limited settings here. Okay, which is this is something that we have not had much chance to hear about this kind of talk yet. Okay, we always heard about the Luticaviir or whatever, but this is something that will be of interest to many of us here. So I would like to thank all of you that to come for this meeting and attending the last session like this. Okay, also would like to thank our speakers, panels, our sponsors to help making this meeting successful. So at least, if you don't come every year, at least every 2 years, I'm sure that you will be updated on HIV. And please travel back safely home and use whatever you learn. Try to do something. Try to push something. Try to push something with the government to do something that you think will be beneficial for your patients and for your country. Thank you very much. I will end this official meeting right here. Thank you.